Good morning, good afternoon, good evening, clinical problem solvers. Good to see everyone today for Neuro VMR. And to expedite our process and not spend too much time waiting for volunteers, Valeria and friends have kindly set everything up for us as far as presenters and discussants. So Valeria, do you want to introduce our colleagues? And then Ibrahim has an announcement, and then we will go ahead.
Today we're joined by an amazing team. Mukund and Aye are joining us. Aye is a first-time discussant, so I will let them introduce themselves.
Hi everyone, I'm A. I'm a medical doctor from VMR, but now residing in St. Louis, Missouri. And I will be applying neurology residency here in the United States. This is my first time discussing, so I'm so excited.
Great, we're excited to have you. Mukund?
Yeah, hey everybody, I'm Mukund, CP Solvers team member, part of the Space Learning Series program, but just did a month of neurology at the San Francisco General Hospital and really liked it. So I have some cases for you from that month to present, including this one.
Fantastic. All right, before we get started, Ibrahim has an announcement.
So thank you, Aaron. My name is Ibrahim Umar. I'm a CP Solvers member, and I just wanted to remind everyone here today that we have a TP recap episode happening immediately after this Neuro VMR. It's not on the same link, but I'll make sure to send the Zoom link as we approach the end of this case. So the mic, I guess, goes back to you, Aaron.
That means we will have to make a historical feat this morning, which is to end VMR before 9 o'clock, which I don't think has ever happened, but we will try. Okay, with that, Mukund, if you could give us just the chief concern only, and then A and I will discuss, and then we'll go from there.
Sounds good to me. So the chief concern is involuntary arm movements.
Involuntary arm movements. Okay, A, what comes to mind when you hear this?
So involuntary arm movements. So I'm thinking that could be like seizures or any movement disorders. So I will be like, so in seizures, it could be, so it's just arms, so like focus seizures. Focus seizures with like preserved awareness. Depending on the site of lesions, there could be like involuntary movements in one limb or legs. There could also be like focus seizures without awareness, like called complex seizures, like in temporal epilepsy. There's like automedicines. So there's like lip smackings and chewings, and like the hands are like going around, like picking up things, and then like buttoning up the shirts. So they could also be present with involuntary arm movements. And they also like myoclonic epilepsy. In like juvenile myoclonic epilepsy, there's like very rapid jerky myoclonic jerky movements, and like when they're like holding things, it looks like they're throwing it away. And then there could also be like psychogenic non-epileptic seizures. These kind of seizures can present with involuntary arm movement, but not like, I don't think like in generalized tonic-clonics, because in generalized tonic-clonics, it will be like all stiffness in all of limbs and then jerky movements. So another could be like any movement disorder. So I will ask whether it is, what kind of movement it is, rather than like localizing or depending on time course. So I would just ask what type of like movement is that? Is it like tremor, dystonia, like a chorea, hemibolismus, like ecdysis, or is it a dystonia, or like tics? So any movement disorders can present with involuntary arm movements. So like essential tremors, they are mostly action tremors. So it's more prominent when you're like holding things. It is like rapid oscillatory movements of like flexion extension movements. And so that is essential tremors. And then like there could be resting tremors of the hands, like in Parkinson's. So it's pretty obvious when it's resting, and then it could be present with bradykinesia or like muscle rigidity, like cochlear rigidities. So we can ask like it has slow enough movement, especially it's like when initiating movement. So it's hard to like put on shoes, or like when starting initiating like walking or like turning around, or like also like turning in bed from side to side. So that could be like essential trauma, resting trauma, and also be like cerebellar trauma, where it is it's also like action trauma when it's near the target, and it could be present with other cerebellar signs like dysarthria, ataxia, dysdiadochokinesia. So it could be trauma, and then so chorea is like dancing movement. So it could be present with like after post-streptococcal infections, like sydenham chorea. And then could be chorea, and then polisma or like hemipolisma, where you have subthalamic inverse. And then there could be like atetosis and dystonia. Dystonia can present with like very sustained muscle contraction. I'm seeing dystonia in like Parkinson's disease, especially. So my mentor always say, hey, this is dystonia, it's not resting trauma. And some kind of like dystonia, text-specific dystonia like writer's cramp, it is present when you are like writing or playing some musical instruments. There is like torticollis is just like neck twisting. So yeah, dystonia. And then tics. Tics are just mostly prominent on like facial marks, like grimace or like eye blinking. But also could be present with any movements. Yeah. And so these are all like neurological disorders. Could also be present in like psychiatric disorder, like REM sleep behavior disorders, where there's like hypnagogics, or it's like dream and acting. So it's like they are like kicking or moving or running away while they are sleeping, because these REM sleep behavior disorders mostly like correlate with neurodegenerative disorder later in life. So it could be sleep disorders, and yeah, any psychiatric or psychogenic symptoms can present with also with involuntary movements.
Phenomenal discussion, A. Okay, so there's a lot there. Let's summarize a little bit. So we're hearing involuntary arm movements, and A told us from the beginning. First, things that come to mind, could these be seizures? If the patient's reporting them, they would have to be some type of focal seizure, because if it's a generalized seizure or the awareness is impaired, the patient wouldn't necessarily know they were moving. So seizure is one possibility, and then movement disorders. And A gave us a master class on all the different types of movement disorders that can cause abnormal limb movements, whether those are tremor, choreiform, dystonic, etc. Other categories you could think about, fasciculations,
Yeah.
usually a muscle across a joint, but the patient may describe some abnormal muscle movements. So fasciculations is another category of abnormal movement that the patient may describe, but it's usually just twitches. Again, the muscle, the arm shouldn't actually move, so probably not. And then sometimes patients will use the term involuntary arm movement, or say arm has a mind of its own, when the patient has the alien hand. Alien hand is a phenomenon that's usually parietal, I believe, or can be supplementary motor. Someone will have to fact check me. That's my recollection, but it can be caused by stroke. That's very uncommon. I've seen it usually with corticobasal syndrome, which is a neurodegenerative disorder, where the patient will just say, it's usually not as dramatic as you read in something like Oliver Sacks, where the one hand is buttoning the shirt and the other hand is unbuttoning it. Usually one patient told me just their hand can come up sometimes, and they don't know why it came up there. So that can be a sign of either a focal contralateral lesion or corticobasal syndrome, are the two contexts I've seen that in. So those are probably the big categories: seizure, movement disorder, alien hand is pretty rare. Fasciculations maybe. And then there is this condition, anti-LGI1 encephalitis, which often begins with these faciobrachial dystonic seizures. It's due to what used to be called voltage-gated potassium channel antibodies, but they were split. That antibody, if you see it, is usually irrelevant unless there is also either LGI1 or Casper2. And the LGI1 syndrome, the patient presents with these faciobrachial dystonic seizures that are very brief, and the patient is awake and alert. And last I read about them, it's not clear if they're seizures or movement disorder, or maybe something in between. Okay, so just briefly, what are the main questions you're listening for on the history to try to get a sense of, are these seizures, movement disorders, alien hand, something else? What are the main questions you want to hear the answers to when Mukund is giving us the history?
Yeah, so I will ask like how it is started and how long it has been like presenting. So like the time course. Then I will ask how it's affecting, like is it start from VMR and then like is it like bilaterally presenting or type of movements, how it is presenting the movement symptoms. And then I will also ask about like other associated neurological like symptoms.
Yeah, perfect. So probably a big thing on my mind is, well, first I should say, this is a little bit of a false exercise we're doing, right? Because in real life, the patient would walk into the clinic while you're taking the history, maybe you're observing these movements already. So sometimes in real life, the exam is happening before even the history. But for the purpose of this academic exercise, right, we want to know, is this unilateral or bilateral, as A said? If this is a seizure or a movement disorder, and it's just on one side, we're really very concerned about a contralateral lesion. How is this, if we're not seeing it and it's something intermittent that we're not seeing in front of us, asking the patient to describe it. As A had mentioned earlier, is it something that they noticed at rest or with action? If this is some type of tremor, any other parts of the body involved, any other associated symptoms A mentioned earlier. If this happens to be a tremor and it happens to be a resting tremor, we want to ask questions related to other signs of Parkinsonism, such as slowing of movements, difficulty with complex movements like getting in and out of a car, rolling over in bed, these types of things. And of course, we're very curious the age of this patient. If this is a child who had a streptococcal infection a few weeks ago, I already mentioned maybe we'd be wondering about synonyms. Korea, if this is an older person with a bilateral syndrome, maybe you'd wonder about a paraneoplastic movement disorder. If it's focal and older, you might worry about a focal lesion. So, and then A said, of course, the time course is something that happens suddenly, which would make us think of certain etiologies we'll get into, or happen more gradually, which would make us think of other things. Okay, so I leave it to you, Mukund, how you want to present this case. In real life, you were seeing the movement before the history. If you want to present in the traditional way, we can certainly do it that way, or however you feel is will be most educational for our discussion.
Sounds good. So I'll give you some of the history to start. This is a 37-year-old male patient. He notices that his right arm started moving 6 to 7 days ago while he was at work. He felt restless, like he had to move it, like it needed to be moved. The movements are irregular, they're not stereotyped. He also endorses anxiety and a non-specific headache that developed around the same time. The headache was moderate, initially 6 out of 10, and has since become much better, but still persistent. He also notes difficulty walking, although he hasn't noticed any falls. And he's had a 10-pound weight loss in the last 2 weeks, which he attributes to not feeling a desire to eat. He denies fevers, chills, dyspnea, nausea, vomiting, diarrhea, and dysphagia. As far as a past medical history, do you want the past medical history now too?
Up to you. Yeah, he's 37, so well,
Yeah.
either way, let's say if there's not much salient in the bottom corner there, we can just round it out. If there's some huge thing that will be a pivot point, we can talk about what we have so far before you put it in.
Yeah, there is an interesting piece of information in the rest of the history, so maybe I'll pause for a second.
Sure thing. Okay, we have a lot of information that we were looking for here. How does this help you refine the differential diagnosis at this stage?
Yeah, so as far as I'm concerned, it has like irregular, restless, stereotype movements. Could be like focused seizures because it is also presenting with difficulty in walking. And I'm just curious, is there difficulty in walking? Is it bilateral or is it on one side?
Mukund, was the patient able to say if the walking trouble was unilateral or bilateral? Also, while we're paused, I think, correct me if I'm wrong, Mukund, that the movements were not stereotyped. Is that right?
The movements were not stereotyped.
Stereotype, just okay. So was he able to report unilateral, bilateral as far as the leg and walking, or no?
He wasn't able to give us details. He said he felt difficulty walking, but he wasn't able to elaborate.
Okay, it's all fine. Yeah, so it has difficulty walking and also like 10-pound weight loss. So I'm thinking that could be like tumor or like focal lesions in the brain, like tumor or demyelinating or like inflammatory diseases. Yeah.
Excellent. Okay, so we have a 37-year-old person here with unilateral irregular movements that are not stereotyped. What movement disorder do you think this is, based on what Mukund is saying? Again, bit of a false exercise, right? We would see it in real life. But the arm is moving on its own. It's irregular. It's not stereotyped. Does that sound like any particular movement disorder to you? Or maybe not. That's okay too.
That could also be movement disorders like associating with other focal lesions, or that could also be just focal neurological presentations.
Yeah, so it could be some focal seizure, depend what you mean. Irregular, maybe the jerking is intermittent. And it could be a movement disorder. What movement disorder would sort of be described this way? Irregular, not stereotyped, kind of restless.
Regular stereotype, restless. Like tremor.
Yeah, tremor usually is pretty regular, right? It's pretty kind of yeah, flexion, extension, or pronation, supination. Yeah, the irregular aspect makes me think more of something chorea athetoid. I think of chorea like the atrial fibrillation of movement disorders. It's irregularly irregular, kind of doesn't have a pattern. It just kind of keeps going in its own way. So whether it's a seizure or a movement disorder, it's on just one side. So you said this sounds like a focal lesion. You mentioned some things that could be tumor. Anything else that you would think of just differential diagnosis wise for this patient with a few days of worsening or a week or so of worsening unilateral movements, just as far as etiology?
Yeah, that could also be inflammatory or like demyelinating diseases.
Yeah, inflammatory demyelinating could be. Yeah, I don't I guess it's possible. Yeah, I don't typically associate them necessarily with a movement disorder. Where would if it's a movement disorder such as chorea, not seizure, where would the lesion have to be, do you think?
Yeah, in the brain, like so demyelinating in the brain or like inflammatory focal like lesions in the brain.
Yeah, and where specifically would you think in the brain if it's a
Mhm.
new onset unilateral movement disorder?
So mostly like movement disorders are in the basal ganglia. But also that could be like in the cortical lobes, like motor cortex. Yeah.
Yeah, so if it's seizure, yeah, we would think it's somewhere in the contralateral motor regions, could be depending on the type of movement, primary motor, or you can get some more peculiar movements in supplemental motor areas. And if it's a movement disorder, it's usually in the basal ganglia. You mentioned something, it's a great point earlier, that we like to localize in neurology and say exactly where the problem is, but the movement disorders themselves don't necessarily localize that specifically. It's not like you can say tic is in this part of the basal ganglia and chorea is in this part. Usually it just when it's lesional, localized a little more to the basal ganglia in general, but it's hard to say specifically, except for one movement disorder that the STEP really loves, which is hemibolismus, right? It's very rare in practice. Where do you know, where hemibolismus localizes to?
And subthalamic nucleus.
Brilliant. Yeah, subthalamic nucleus. Have you seen in your practice cases of hemibolismus from a subthalamic nucleus stroke or hemorrhage?
Not yet.
Yeah, step one, not yet. One of my co-residents had one case from a small hemorrhage, but what's something people don't often think of, but that can cause hemichorea that's not lesional? Do you know another cause of hemichorea,
Korea, like CJD.
Probably CJD can do anything at first presentation. Can maybe have some movement disorder. I'm not
Or
sure.
Huntington disease.
Which one?
Huntington disease.
I didn't hear you, sorry.
Is it like Huntington disease?
Oh, Huntington disease. Right. Probably this is a little fast for Huntington's disease and it's unilateral, probably bilateral, but there's some anxiety and some movement, so maybe. There's an electrolyte or
Hyperglycemia, or like, other electrolytes.
yeah, very peculiar hyperglycemic hemichorea. For some reason, even though the blood glucose is abnormal in the whole brain, you can get hyperglycemic hemichorea. Years ago now, Gabby, who's at University of Pittsburgh now, presented us a case with a video of hyperglycemic hemichorea. You can get hyperglycemic focal seizures, actually, described by one of my professors in Boston, Nagagopal Venna, in the probably late 90s, early 2000s. Okay, so a big branch point in this case, right, is going to be, is there something on the image? Then we know there's a lesion there causing this or not. We have this weight loss. We have this headache. We have this focality. Does make us think there's something on one side, probably some type of expanding lesion if there's headache with it. And then the weight loss. If you heard this story, or we are hearing this story, so this 37-year-old man, weight loss, new focal unilateral seizure or movement disorder. There's something coming to mind for me. How about, it's a little bit guess what I'm thinking, but you mentioned tumor. He's young, we think healthy, but losing weight, but 37-year-old. I suppose could have a primary brain tumor causing these things. You mentioned inflammation. Having little trouble thinking of where I would put a demyelinating white matter lesion to cause this, but maybe. There's another category we haven't mentioned, though, that I'm thinking of here.
Like paraneoplastic?
Yeah, paraneoplastic chorea, I've never seen. It's possible. Usually it's going to be bilateral. I think the antibodies are CRIMP5, and I think you can see it in IGLON5 also. I haven't seen either of those in real life. Any infections come to mind that can sometimes present with a basal ganglia lesion and a contralateral movement disorder? Any infections? There's an infection in patients who are immunocompromised, particularly patients with HIV, that for some reason likes the basal ganglia as a place to grow. Do you know what I'm thinking of? A little bit, guess what I'm thinking, Sorry. Toxoplasmosis. You can go anywhere, toxoplasmosis, but you can get toxoplasmosis in the basal ganglia presenting with contralateral hemichorea. So with this weight loss, young man, new movement disorder, San Francisco General Hospital, where Mukund mentioned is our public hospital in San Francisco. No reason you would know this. This is local knowledge, but we see a large proportion of the patients in San Francisco who have HIV and sometimes, unfortunately, presenting with a very low CD4 count and AIDS-defining illness at presentation. Okay. You want to go ahead and give us some more information, Mukund?
Yeah, that sounds good. I'll give you the rest of this bottom left quadrant, and I think in the interest of time, we'll maybe give you the physical exam as well. So there was a big branch point, and many of you are right on the nose here, including in the chat. His past medical history is notable for a diagnosis of HIV, which interestingly enough did not come up in our initial interview and history taking. It came up later. So this kind of also changed the way we approach the case diagnostically, but he does have a diagnosis of HIV. He was diagnosed in Mexico several years ago, and he's not on antiretroviral medication. For medications, he's taking none. His family history is not notable for anything neurological. As far as a social history, he works in a restaurant. He immigrated from Mexico 2 years ago. And as far as health-related behaviors, he drinks anywhere from 5 to 10 beers every night. For a physical exam, do you want to
Sorry,
stop here? Do you want to keep going?
Just before the physical, just we'll pause for a second. I know we have a few more aliquots left, I imagine, but just quickly to hash this out. So with HIV, what's our sort of differential diagnosis for a new focal brain lesion? HIV can affect any level of the nervous system, but for a focal brain lesion in particular, what are you thinking of?
Yeah. So with HIV and focal lesions, be like HIV associated like leukoencephalopathy.
Usually that's going to be which do you mean, the primary HIV?
Leukoencephalopathy.
Do you mean progressive multifocal leukoencephalopathy?
Leukoencephalopathy, yes.
Yeah. So that's PML from JC virus. Yep, that can cause a focal lesion. Yeah. What else?
Yeah, that could also be like due to other infections because he is immunocompromised and not taking any HIV medications, like opportunistic infections, and could also be like other inflammatory focal diseases in brain.
Yeah.
I cannot talk about like specific names or things like that.
No problem. Excellent. Yeah. So HIV can affect the nervous system really in 3 ways. One is primary involvement by the virus itself, HIV. We'll talk about that in a second. One is opportunistic infections, as A mentioned, and then one is a complication of treatment. So the HIV itself at the time of seroconversion can cause a viral meningitis, can cause a Guillain-Barré-like syndrome, though with cells in the CSF, and can cause unilateral or bilateral facial weakness. The only one of these I've seen in practice is the viral meningitis. Importantly, at the time of seroconversion, the antibody is still negative, so you'd have to check a viral load. Later in the course of the illness, you can get HIV neuropathy. You can also get HIV dementia, now called HAND, HIV-associated neurocognitive disorder, which ranges from sort of a subclinical cognitive impairment to dementia. You can get an HIV myelopathy. Spinal cord disease is usually very late and pretty uncommon in the treatment era. And then there are other rare things you can get from HIV primarily. And then opportunistic infections, Cryptococcus, that's a meningitis, that's not the syndrome this patient has. Focal lesions, A mentioned PML from JC virus. There's toxoplasmosis. There's primary CNS lymphoma, EBV driven in this population. This patient, I'm not sure how much tuberculosis there is in the part of Mexico that this patient may be from, but tuberculosis, tuberculoma, something to consider as well. And then some of the older medicines we don't use too much in the US, but are still used worldwide. The so-called D drugs, didanosine, stavudine, and zalcitabine can cause peripheral neuropathy, and efavirenz can cause altered mental status. But here we're in the family of focal lesions, so we'll want to focus our exam on seeing what this movement disorder is and any other signs of focality or multifocality. And then obviously this patient is going to need some brain imaging to see what's going on and try to go from there. Okay, Mukund, what did you find on the exam? What movement disorder is this?
Sure. So as far as an exam, vitals were all within normal range. I'm going to focus on the neuro exam here, where all of the interesting findings are. So for mental status, he's awake, alert, he's oriented to self and place, but not to the year. Although if you give him 3 options for years, he chooses the right one. His speech is fluent but sparse. His repetition is intact, his naming is intact, and he follows commands. For cranial nerves, his pupils are equal, round, and reactive to light. His extraocular movements are intact, but with impaired burying of the sclera on both left and right lateral gaze. He has a very mild right ptosis. he has trace right lower facial weakness, and facial sensation is intact to light touch. For a motor exam, he has normal bulk, normal tone. In the upper extremities of what we tested, his wrist extensors were 5 and 5, right and left, and his finger extensors were 4+ on the right, 5 on the left. In his lower extremities, his IPs were full strength bilaterally, his quads, his hamstrings, and his TA were 5 out of 5 strength bilaterally. He has a right downward drift without pronation when you assess for pronator drift, and his finger taps are slowed on the right. For sensation, is intact to light touch globally. For a cerebellar exam, his finger is intact on both sides, but more effortful on the right. And as far as the movements, you kind of get irregularly spaced, irregular appearing, low amplitude motions of the right arm and occasional wriggling motions of the right fingers.
Excellent. Okay, there's a lot going on here. First, what's the movement disorder?
Sounds like atetosis for me.
Yeah, sounds like choreoathetosis. It's irregular, it's kind of moving around. Again, they say picture is worth 1,000 words for movement disorder. Video is worth 10,000 words to describe a movement disorder. A little tricky, but I think, yeah, Mukund is trying to tell us there is choreoathetoid movements here. And then what do you make of the rest of these findings? Can we fold this all into one lesion, which we usually try to do first, although some patients have multifocal lesions. What do you think? Are the other findings, can we put them all into one place, or do we need multiple places?
So it has like right mitosis. So it's affecting like cranial nerve 3. And there is right lower facial weakness, so cranial nerve 7. Sparing the forehead, so it's upper motor neuron lesions, and the pupils are all equal and round, and there is in motor systems, it is it looks like all normal. So I'm just thinking it could be like in somewhere in the cortical area and not specifically like in brain stems. Yeah.
Yeah, the chorea itself, it's unilateral, so we won't go into it in the interest of time, but we've discussed before in this conference, and maybe someone can find, I think I made some figures about this with Reza a long time ago. For the movement disorders, the most important thing is to figure out which movement it is, because whether it's tremor, chorea, dystonia, tic, all the things A gave us a beautiful masterclass on earlier, each have their own differential diagnosis, which I divide into either a structural lesion, a primary neurologic disorder, often neurodegenerative, some type of systemic process, or drug-induced process. And each movement disorder, I have a whole table of this, has sort of different things in this category. So for chorea, neurodegenerative disorders, Huntington's and others, lesional, if it's unilateral, something like a basal ganglia lesion, systemic disorders, you have Sydenham's chorea. You can get chorea with polycythemia vera, though I've never seen that, hyperglycemic hemichorea. There's drugs that can cause chorea. I think cocaine, methamphetamine. I think levodopa can sometimes cause chorea, although maybe I've seen that written in tables. Maybe they just mean the choreiform nature of dyskinesia, as you can see. But okay, so we definitely have something in the basal ganglia, and you correctly identified, we don't have time to go into too much depth on it, upper motor neuron pattern facial weakness on the right, so we must be in the left hemisphere somewhere. So if we have a basal ganglia lesion and some upper motor neuron pattern facial weakness, can you draw in your mind one lesion A that would give you basal ganglia and some subtle face, and it looks like there's some subtle finger extensor, so a little bit of face hand weakness plus the chorea. Can you put that all in one place? It's hard, but what do you think?
Mm. It could be like,
Let me give you oh, sorry, go ahead, and then I can give you a clue if you want some help.
yeah, yeah, like in parietal lobes or um,
Yeah, what I'm thinking is we have to have a basal ganglia lesion, I think. And then what white matter runs right next to the basal ganglia, the internal capsule. So I suspect this is a lesion in the basal ganglia that is either causing mass effect on the capsule or maybe extending into the capsule, so that you're getting a movement disorder as the main feature, but some subtle weakness on the side that's affected by the movement disorder. Two findings we can't put with that. One is ptosis. As you said, it could be a third nerve palsy, but the rest of the movements of the third nerve are okay. The pupil is okay, so probably not. Could be Horner's syndrome, but the pupils are okay. And why would you get Horner's? That's a totally different location and pathway. What I guess this is probably, unless there's another lesion somewhere, I'm not sure where I'd put it to get isolated ptosis. We say upper motor neuron facial weakness spares the upper face, but you can get a very little bit of upper motor neuron. You can get a little bit of upper facial weakness with upper motor neuron. That's usually not the main feature, but sometimes it looks, you can see it's a little bit involved. Maybe that's that. And what about the difficulty bearing the sclera on the left or right? Did you know what to make of that, A? So bearing the sclera, when the patient tries to look laterally, the right eye isn't getting all the way over and the left eye isn't getting all the way over. What does that mean?
yeah, so it has like gaze palsy, like super nuclear gaze lesion.
I don't think he's describing, sorry, it's a little, I'm squinting also because it's written so small on the screen. I think he doesn't mean a gaze deviation, but when the patient looks all the way to one side, the right eye when looking to the right isn't getting fully there, and the left eye when looking to the left isn't getting fully there. Yeah, he's saying yes. So what is that? What action is affected?
So when the right end is like they are on the right gaze, there could be like lesions in right lateral radius, so sixth nerve palsy, and then for the left eye there could be like third nerve.
So the left eye is okay, he's telling us, yeah. So when he looks to the right eye is not making it, but the left eye is okay. Correct me if I'm wrong, Mukund. And when looking to the left, the right eye is okay, but the left eye is not making it.
Okay, so there is like six nerve palsy in the left side too. Okay,
Yeah,
so-
what do you do with bilateral six nerve palsies in this case? How do you explain that?
That couldn't be bilateral like lesions, but it's not disease. Could be like increased intracranial pressure.
Yeah, perfect.
Yeah.
Yeah, perfect. So, right, so the sixth nerve nucleus is in the pons. As A said, we can't have bilateral pontine lesions here, and the patient's awake and has such minimal deficits, and it wouldn't cause a movement disorder. But the sixth nerve has this kind of long, tortuous intracranial course over the clivus and into the orbit through the cavernous sinus. And when intracranial pressure is high, you can get unilateral or bilateral sixth nerve palsy. It's called a false localizing sign because it looks very focal, but it's actually not. So if we wanted to put all of these patient's symptoms, all of these symptoms from this patient in one lesion, we'd have to invoke something in the left basal ganglia, pressing on or extending into the left internal capsule, big enough to be causing some elevated intracranial pressure with bilateral sixth nerve palsies. And the finding we'd have to toss is the right ptosis and say it's just the face is a little weak on that side. Okay. What did you make of this ptosis, Mukund? We're not seeing it, so you saw it. For me, if you have ptosis and the pupil is okay, and the eye movements related to 3 are okay, and it's not a Horner's, either it's some in an older person levator problem, myasthenia, which then we're really giving this patient too many diseases, or if there is facial weakness, sometimes you say, well, every once in a while you see a little bit of lid involvement in the upper motor neuron facial. What did you all make of that finding, Mukund? That's the only one we can't fit in here.
Yeah, I think our thought process was very similar. All of the rest of them generally fit. The ptosis is, I mean, it was quite subtle as well. So I think ultimately the same thought process as you.
Okay, you tossed it. Okay, or thought it was part of just the package of facial weakness. Okay, we already know this patient has HIV. One thing that helps us understand the differential, in addition to looking at a picture, is what lab test. If you could see one lab in this patient that would help us know what he's at risk for from the perspective of HIV, what lab value would you want to see? A lab related to the HIV that will help us know what he's at risk for.
Yeah, so definitely HIV viral loads and then other opportunistic infections screen.
Yeah, so the viral load will tell us probably it's going to be quite high. He's not on any treatment, but particularly the CD4 count, CD4, the T cell subsets. Because if this patient's CD4 count is higher than 200, and has consistently been higher than 200, then the patient may not be very immunocompromised, and we have to think of whatever we see on the brain imaging in that context. If it's below 200, especially below 100, then really any of the opportunistic infections are at play here. Okay, so you can tell us quickly, Mukund, if there's any systemic labs of interest aside from the CD4 count, which I'm going to guess is pretty low if there's no treatment and an AIDS what we suspect is an AIDS defining illness. And then hopefully we get to see some pictures and A and I can interpret the neuroradiology.
Yes, absolutely. So yeah, I'm gonna give you just the HIV labs and then go straight to the imaging. I think in large part because that's how we got the info. He went to the MR pretty quickly, but also because, as we will see shortly, there were some diagnostic hiccups that are picked up on MR. So his HIV rapid test was positive. His viral load was 541,000. And his CD4 count was 32.
32. Okay, so he is at risk for every possible opportunistic infection. Some books and charts, I looked this up when I was working on my book, and it's a little different everywhere, but say that there's different things you're at risk for when you're between less than 200, but still above 100, and then less than 100, and then I think CMV, you're really not supposed to get to you're less than 50. But here we don't have to worry about any of these things because it's so low. But if it was in the hundreds or 200s, maybe we might try to use that if the brain imaging is not definitive, but I've never been sure. If someone knows better than me, if there may be an HIV expert on our session this morning, let me know. But I think less than 200 sort of at risk for almost everything, although maybe lower puts you at risk for different things, but I'm not 100% sure I found a definitive answer there. But certainly 32 at risk for everything. Okay.
All right.
So what did we see on the imaging?
I will share some imaging. I have a few sequences to show you as screenshots, so I'm going to share my screen now. Can someone allow me to share my screen?
Oh, someone make him a co-host. And then just to make sure, Mukund, while you're playing that, there's no PHI in the image, is that right?
There's no PHI.
Fantastic. Thanks for removing that. Okay, you should be able to share now.
Okay, very good. Can you see the screen?
Yikes. Okay, what sequence is this and what do you see?
It is MRI T2 data.
Yeah.
And
Particularly which type of T2?
T2 flare.
T2 flare, right? The gray matter is bright, the white matter is dark, and the CSF is subtracted out. Okay, and so what do you see here?
And there is like big hyper intensity and like edema like all around the basal ganglia and also like in this parietal lobes. And but there's like gray white matter junction is preserved.
Mm-hmm.
Mm.
I agree with you. We see in this right image what look like two focal lesions in the thalamus on the left, and
Yeah.
then maybe anterior thalamus on the right with a lot of edema. And then, as you said, there's a little bit of hyperintensity in the posterior, looks like the occipital pole there, and maybe a hint on the left of a lesion in there. And then it looks like there's some abnormal signal in that occipital horn of that right lateral ventricle. And it looks like the edema, we don't know if there are more lesions, but the edema is actually extending down into the midbrain. Okay, so it's very abnormal, not specific yet, but, and then what sequence would you want to look at next? What do you predict Mukund is going to show us next here? What sequence would help you get a better sense of what these are?
Then diffusion weighted.
Yeah, diffusion weighted could be helpful. I agree. There's probably one sequence I would be curious to look at first.
T1.
Yeah, particularly T1 with contrast, right? With contrast, yeah. So now we see there's abnormality here. The T2 hyperintensity is not specific. There's a hint of these circular lesions there in the center of that edema on the right. So I would want to now know if these are contrast enhancing and what their morphology is. Are they homogeneously enhancing, ring enhancing? I suspect these are going to be ring enhancing. Okay, do you have a T1 post for us next, Mukund?
Certainly do.
Okay, now what do you see, A?
So this is ring and enhancing lesions. Probably like toxoplasmosis.
Yeah, excellent. So perfect. Yeah, you went right for it. So these are 3 ring enhancing lesions, and we see that now that edema is dark, but these are thick rings, 3 of them, 2 deep, and then 1 posterior there we see on the left image. This is a very subtle radiologic sign, but that left image has what's called eccentric target sign, which is supposed to be pretty specific for toxoplasmosis, although it's not sensitive. Eccentric target means you see that little thing, maybe about 7 o'clock on the clock there. It's not in every toxo case. I've read, people always say it's 30% sensitive in the literature. I've gone down the rabbit hole of trying to find the source of that and can't find it. And I've asked my neuro ID colleagues, no one knows where that number comes from, but it's supposed to be relatively specific for distinguishing from other ring enhancing lesions. When you see a ring enhancing lesion in an HIV patient, toxo is possible. What else is possible here? And maybe this is the diagnostic hiccup Mukund is alluding to. There's sort of a main differential between
like CNS lymphoma.
primary CNS
Right.
lymphoma. Yeah. Is there any way to distinguish those, A?
Lymphoma could be like there is a breakdown in the ring, like it's not closed, closed ring.
Yeah, the open ring is usually with demyelination, my understanding. So it's very hard to distinguish primary CNS lymphoma from toxo in the immunocompromised patient. They both look like a ring. They can be anywhere. In my experience, toxo is more common, at least in the US. I don't know why that is than lymphoma. But that's usually the dilemma. Of course, it could also be bacterial abscess. The patient could have endocarditis and have multifocal abscess, could be tuberculosis. So what would you do next, A, to try to figure out what this is?
You mean like in imaging?
Any test you want, you can have. What test would you want to get?
Okay, so I will get toxoplasma antigen test, and then like complete black count, and like hemoglobin, and then I want to see like eosinophil rising amount. Yeah.
Yeah, so these are tough cases. There's a couple things you can do to proceed. You can get a toxoplasmosis IgG from the serum, but many of us have a positive toxoplasmosis IgG. It's very common to be exposed, but it doesn't prove that what you have in the brain is toxo. Some people say if the IgG is negative, it makes it unlikely it's toxo, but if a patient's very immunocompromised, they may have a low titer, and so we can't really use that. The definitive test for toxo is a CSF PCR test. However, most patients like this patient have so much mass effect that it's not really safe to do the lumbar puncture, so you can't get that test. So what the guidelines suggest, I don't know if there are guidelines or what guidance suggests, my understanding in these cases is if you're between toxo and lymphoma, and you can't do a lumbar puncture, you treat for 2 weeks with toxoplasmosis treatment, and then you re-image and evaluate the patient. And if the lesions are improving at the 2-week mark, you presume you were correct and you can continue treating for toxo. If the lesions are worsening, expanding, the patient is worsening, expanding, you need to do a biopsy, because really it can be anything: tuberculosis, nocardia, lymphoma, bacterial. But if there's no signal for bacterial, you're not worried the patient could have endocarditis, IV drug user, something like that, then in that case, you would treat empirically for toxo and reevaluate. So what did you and your colleagues at the general do, Mukund?
Sure. So yeah, I mean, your point is exactly right. You can have any lab you want except the lab you really want. It was deemed unsafe to do a lumbar puncture for this patient. The MRI read came back with findings notable for right ventricular hydrocephalus entrapping, and a 2 to 3 millimeter midline shift. And on the coronal view, which I don't have, unfortunately, you can actually see the mass effects kind of impinging on kind of peri-brainstem structures a little more clearly. So it was deemed unsafe to do a lumbar puncture, and we have gone ahead with exactly the plan that you've mentioned. I have a variety of serum labs, which we have drawn as kind of our best second, line of diagnostic workup for this patient in the absence of CSF. So I'll tell you about some of them now. For a CBC, white blood cell count of 2.8, of which 1.42 were neutrophils, hemoglobin of 13.8, platelets of 251, basic metabolic panel, including blood glucose, was totally normal. AST of 40, ALT of 71, both mildly elevated. Alk Phos of 77, which is normal, a T-Billy of 0.2, which is low, and albumin of 4.4, which is normal. And ANA was positive with a titer of 1 to 80. As far as infectious studies, we talked about HIV stuff already. A hepatitis panel was sent. Hep A IgG was positive, but IgM was negative. He was not immune to Hep B, but had never been exposed. And Hep C was negative. A serum cryptococcal antibody was non-reactive. A serum toxo IgG was positive, but IgM was negative. RPR was negative. Serum JC virus PCR was negative. EBV capsid and EB nuclear antigen IgG were positive, but IgM was negative. Beta-D-glucan and galactomannan were negative. Stool, ova, and parasites were negative. And as far as some other miscellaneous labs, a beta-tube microglobulin was slightly elevated to 2.8, with a normal being upper end of 2.4. And LDH was 205, which is normal. And a lipid panel was sent and notable for an HDL of 39, which is a little low, with normal starting at 40.
Okay. Any of these labs helpful to you, A?
Yeah, so toxoplasma positive, and also other like hepatitis, and ANA is positive. I'm curious about like with ANA positive.
Yeah. I don't know what to do with all these labs. Yeah, the toxo IgG is positive. Many of us on this session this morning have a positive toxo IgG. Doesn't matter if you're if there's no immunocompromise. So the fact that it's positive here doesn't tell us that what's in the brain is toxo. And then, yeah, a lot of labs were sent here. The JC virus, this is not what PML looks like. It looks like juxtacortical, non-enhancing white matter lesions, usually going to the, always in my experience, going to the U fibers or in the middle cerebellar peduncle, rarely enhancing except in the context of iris. It was not PML. The EBV tests were trying to triangulate, could this be an EBV-driven lymphoma? I don't know enough about EBV to know what to make of these particular labs, but if you had CSF and had a very high EBV, I guess it's a viral load you would check. I'm actually not sure. That might make you worry about lymphoma. But in my experience with these patients, you can send every lab in the world that you want. You're not going to figure it out. unless you can get CSF, which usually you can't. A lot of these are small lesions, right? But lots of edema, which is classic for a toxo. So in this case, I appreciate the treating providers were trying to find some additional hook, some additional guidance, but in my experience, usually don't find it. The toxo serologies are reasonable to send because if they're negative, maybe you raise an eyebrow, but even still, I would treat this patient for toxo and re-image them in 2 weeks and see if we've made progress. And if not, you can send lots of other labs, but probably you're going to need to do a brain biopsy. So do we have the follow-up, Mukund, of what happened 2 weeks later?
So this is very much still an active case, but the treatment plan is as you described. He was started on pyrimethamine, sulfadiazine, and leucovorin a few days ago now, and there is a plan to re-image his brain in a little over a week to monitor for progression. But in the meantime, we're treating this presumptively as CNS toxoplasmosis.
Excellent. Yeah, and another thing is, unless you try to avoid steroids in these cases, because if you are biopsying them later and it's lymphoma, it can melt the lymphoma and you get an ambiguous biopsy. So yeah, we treat for toxo, and then 1 week may be a little soon to know what's going on. I usually wait 2 weeks. Sometimes as you're treating infectious lesions, they might get a little bigger before they get smaller, and then people get scared on that if you scan them too early. Excellent. Well, I hope you'll give us the follow-up, Mukund, so we can know if we were on the right track. And then did radiology agree with me about that eccentric target sign in the right posterior lesion?
They did agree with you about the eccentric target sign. There's also one other interesting teaching point about CNS toxo versus CNS lymphoma that I got from this case. I'm going to share my screen one more time to show you. So here you can see diffusion-weighted images on the top and ADC maps on the bottom. And you can see that these lesions are very weakly diffusion restricting. This was an interesting pearl from radiology that there's a possibility, although it's not particularly specific, of differentiating CNS toxo from CNS lymphoma by its diffusion weighting characteristics, with malignancy being more diffusion restricting than infection. So, all of these generally point toward CNS toxo, but we'll see in a little while.
Yeah, interesting. Thanks. Yeah, I hadn't heard that about the DWI. Lymphoma is interesting because in immunocompetent patients, it's usually homogeneously enhancing and diffusion restricting. But in immunocompromised patients, it's usually ring enhancing. I actually don't know if it's supposed to restrict or not in that context. Sounds like radiology is telling you it is. I've also seen studies of using nuclear imaging, SPECT or PET, and then toxo should be cold and lymphoma should be hot or hypermetabolic, but you don't have that test at the general, and I've never actually seen it used in this context. Fantastic. Any final teaching points here as we wrap up, Mukund, from this case?
No, those were the big ones. I think it was really educational for me to learn about all of this, about the differential for ring enhancing lesions, about how it changes for people in HIV. And in particular, I think some of the management considerations, whether or not to lumbar puncture this patient in particular, was very, very educational.
Fantastic. Yeah, excellent. Any closing reflections from your first time discussing the case with us?
I'm just so excited and nervous about my case. Okay, this is a really great case. I learned a lot. Thank you so much, Aaron.
Yeah, great discussion, you picked up from the beginning this very helpful framework. Could this be seizure or movement disorder? You quickly realize it's a movement disorder. It's focal, so it must be lesional on the contralateral side. You identified the movement disorder as chorea, localized it to the subthalamic region, saw that the weakness probably fits in with that being a lesion in the basal ganglia extending into the capsule. And then we use the ring enhancing lesion aspect to narrow this to probably toxo versus lymphoma with bacterial or TB not being possible as well, and talked about the treatment of a ring enhancing lesion in a patient with HIV and low CD4 as trying to prove toxo, as Mukund and his team did, but couldn't get lumbar puncture in this case, and then just treating and using treatment and time as a diagnostic tool. And if this patient is worsening on treatment, or if this patient is developing new findings, you would re-image sooner and realize maybe you're not on the right path. And the other little management thing that I know we have to let the other session go on is deciding when to start the antiretroviral so you don't develop the complication of iris. I think there's good data for TB. I think for toxo, it's not entirely clear, but usually you wait about a week or two. Some people say 2 to 4 weeks of getting the toxo under control before starting the antiretrovirals. Is that what was done in this case, Mukund?
Yeah, that's exactly right.
Perfect. Okay, sorry to end quickly. We got almost finished by 9, which is a record for us, 9:02. We will close quickly here. Thank you so much, Mukund, for bringing this case, Valley, for organizing, for your brilliant discussion, and to Sasan for scribing here all this information as it came out in real time. Thank you, everyone. Enjoy the next session if you go. Otherwise, enjoy the rest of your day. See you this month, many Tuesday mornings for many Neuro VMRs with Valley, and others. Bye-bye.
Thank you. Thank you, Aaron.
Thank you, everyone.